able to commit to this subcommittee that in addition to the important announcement from HRSA today about rebuilding our nation's transplant infrastructure, organ allocation formulas will be on the table for a complete overhaul, resulting in a more equitable formula.
You have been ringing this bell for quite some time. We took a little time, but we wanted to make sure we could do it right. We are going to open up the process so that this one contractor doesn't believe that it owns this shop.
A big announcement followed by an even bigger promise. Good morning. It's Wednesday, March 29th. I'm Dr. Steve Stites, Chief Medical Officer at the University of Kansas Health System. Welcome back to Open Mics with Dr. Stites. For 5 years, we've been talking about donor liver allocation to anyone who would listen. 1 week ago today, meaningful changes were announced to the federal level to overhaul the process of organ procurement, that is, going out and retrieving organs and then donating or distributing those organs to a patient in need. While this is welcome news, we will explain why this complex and sometimes contentious conversation over organ allocation is far from over. Joining us in the studio, I am surrounded by transplant people, folks. Hopefully I'll get out of here alive today. Joining us in the studio, we have transplant surgeon and vice president of perioperative procedural services here at the health system, Dr. Sean Coomer. Also joining us is the director of transplantation for our entire health system, Dr. Timothy Schmidt. And the gentleman who helps run the medical side of liver transplant, Dr. Ryan Taylor. He's a transplant hepatologist. Thank you all for being here. Remember, I'm healthy right now. All of these distinguished guests have been on the front lines and sometimes in the headlines talking about the dire consequences of drastic changes to liver allocation that were made 3 years ago. But behind the scenes is one man who is part of a national team of legal minds that has been guiding us and legislators to get us to this point. Dan Peters is our Senior Vice President and General Counsel for the health system. As you might imagine, he doesn't like the limelight, but our Jill Chadwick talked to him on camera for a few thoughts. We want to warn you, there is a liver transplant video in this story, but this is a medical program, and we hope you will understand that this is part of the entire story.
It was a big day.
Senior Vice President and General Counsel for the University of Kansas Health System, Dan Peters, reflects on the recent Health and Human Services decision to overhaul the United Network for Organ Sharing, an argument Peters and others have been making for years.
In the past, there's been a single contract to administer the allocation of solid organs around the country. And some of the scrutiny that happened and continues to happen during the course of our litigation exposed some concerns about the way that operation has happened, and different members of Congress got involved, and through our litigation also exposed that maybe it might be better with separation of authority and responsibility.
This is really about life and death.
The stakes grew considerably higher in 2018 when UNOS announced sweeping changes in the allocation of donor livers. Multiple transplant teams, patients, lawyers, and legislators sounded the alarm of devastating consequences. Despite the warnings, UNOS enacted the changes in 2020.
It had an effect of disproportionately impacting regions of the country that are high organ donors. And so certain areas of the country become more net exporters of organs to other areas.
Since 2020, 83% of the University of Kansas Health System donor livers have been exported to transplant programs in Chicago, Minnesota, Oklahoma, and Texas. In a recent hearing, Senator Moran told the HHS secretary that everything experts predicted 3 years ago had come true, with the results published in a Washington Post story for the world to read.
Quoting from the Washington Post story, the analysis from data federal health authorities found sharp declines in life-saving surgeries in Puerto Rico and 7 states: Kansas, Alabama, Louisiana, North Carolina, South Dakota, Iowa, and Pennsylvania.
Peters praised the Post and other media for their reporting and added that true change in organ allocation takes more than legislating and lawyering. It takes organ donation.
If the water level would simply go up and more organs are available, that's good for everyone, for every program.
Until that day, efforts continue to find a fair way to share a scarce resource.
I continue to ask, what does success look like in litigation? The action by the government agency is to change the process. There still remains an allocation formula that we think is producing improper results. That work has to continue.
The work does continue, and as Dan explained, what happened at the federal level is about process, not to be confused with any change to the current allocation system. So what is the change in process? Health and Human Services is calling it a Modernization Initiative to strengthen accountability and transparency. There's a lot of words there. If you want to read it yourself, scan the QR code here on the screen. In short, the revamp promises a performance dashboard detailing organ retrieval, waitlist outcomes, transplants, and other data by individual transplant center and organ procurement organizations. Okay, that's a lot of words. Dr. Coomer, help us understand what I just said and what does this revamp really mean?
So what essentially happened is it is about the process, and the process of reallocating or the allocation change did not allow us to participate as much. We did participate, we got our word out, but it was not listened to. And that's a problem, because everything we all predicted would happen did happen. So you saw in that video, 80% of livers used to stay here. Now 80% of livers fly out of here. That's a big change for our patients. So what had happened in the allocation model change is they cast a wider net. Instead of local first, it became national first or regional first. And as a result, we became net exporters, and that hurt our patients. So that's the main issue at hand.
So we then did fewer transplants because we didn't have as many organs coming in as we had going out?
Correct.
And essentially then, because we get a lot of donors in our area, we sent those outside, even though the people who you would have thought maybe meant to get those organs, the folks who live in our area, they weren't getting those organs.
Absolutely correct. That frames it perfectly.
All right, so if let's take a look then. The United Network for Organ Sharing, or UNOS, has been the one and only contractor for organ procurement for like 40 years. All right, tell me what that means. Again, interpret my words. Does UNOS need competition?
So it is very interesting. So the UNOS is a private contractor that got the contract from the government for the OPTN from HRSA, and which is a division of the Health and Human Services, which reports to Secretary Becerra. As a result, there has been little to no competition looking at that. They have been able to be a monopoly in the entire process, and also all the organ procurement organizations around the entire country, number 56, I believe, they have monopolies for every area. So there's no inherent competition to really keep people honest. There's not really great checks and balances in the system.
So how did it happen that these changes were even made? I take it must have been that somebody was in control of UNOS, or some group was who was going to benefit from this.
Well, I think that the UNOS certainly, they had selective hearing, and they heard from certain people around the country and decided not to listen to others. And most of us who were involved wanted an academic discussion about the entire process. And that's why it's really important to hear what Dan Peters mentioned. This is about persecution of the process as opposed to the allocation at the end.
Okay, so we're trying to make sure that there's a fair methodology for distribution as well as for trying to get people to donate. Is that kind of part of the story?
Absolutely.
All right, well, the numbers don't lie. We're going to show you the impact of changes that were made a few years ago to the allocation in our program. We have two graphics to show you that date back to 2017. These graphs will give you a very clear picture of what's happening with our patients and our organs. Doctors, I want to ask you to help us walk through this. First, Dr. Schmidt, what's going on here on this table?
I think the first line shows that the number of deceased donors that happen per year. It's about 8,000 to 9,000. And that's also, transplants three parts: donation, allocation and transplant. UNOS really just controls the middle part, allocation. They don't control donation, and they don't control transplant. So the increase in donation is actually not because of UNOS, it's because of most likely the opioid crisis and donor OPOs doing better. The second one is the transplants, the number of transplants we've done per year as a nation, and that's increased as donation has increased. The last line is the one we worry about, is the number of organs that are not used, and we call those discards. And what's the reason for that, we believe, is because the complexity of the process. So say we have a donor here in our area, some center accepts it in Chicago, they look at it and they decide that they can't use it. By that time it has too much cold time and nobody can use it.
Okay,
so that,
tell us what cold time is.
Cold time is the amount of time outside of a body that an organ has before you put it back in.
So in other words, it gets harvested, the donation has been gotten here, it's taken to Chicago, and then in Chicago they decide, well, we don't want it now, we don't like the looks of it, and now we want to try and send it somewhere else. And that all adds up, that cold time outside of the body.
And by that time you can't use it. What used to happen is there was a donor that may have been older or more at risk for having failure afterwards in our region, and we could look on our list and say, well, this person would be perfect for that organ, maybe a little less sick, and would be able to take an insult from a slower functioning organ, and we could use that organ because there's less cold time, less complexity. We just use it. Now there's no way to go down on the list. That patient will be 300, 400 down on the list. Yeah, and so in order to get to that person, that donor has a long route to take.
So ultimately, it sounds like what we're doing is taking, like, some areas were very high donation areas, like Kansas City, and other areas may not have been. Instead of saying, let's go raise the number of organs in this area that's not very high, let's go have a good donor campaign, we decided, well, we're just going to just take the organs from Kansas City and send them to New York or wherever.
Right, we tried to fluff the drapes of a falling down house first. You know, you got to fix the foundation.
Like fluff the drapes of a falling down house first. Go ahead. Yeah, you're back to the foundation.
No. You got the foundation.
Only a surgeon would say something like that. A medical doctor would be like, what?
Coomer and I argued for years that it's the donation is the problem. There's articles out there that show that if you increase donation nationwide, the number of transplants would have gone up by thousands. And allocation doesn't fix donation. It just makes things more complex, and it doesn't address the real problem.
So the rate of donation in one population, Dr. Coomer, may be much different than the rate of donation in another area of the country. Is that really the kind of the...
Absolutely true. So we actually looked at this. Some of this has been published. New York, who has a tremendous amount of liver disease, and they need more livers, their organ conversion rate is much less than around here. So they were on the order of 55%, whereas around in the Kansas City area, we were somewhere around 82, 83%. So right there, you're talking about more donors per capita in our area. And the thing that makes the wasted organs even worse, now obviously all tide rides, basically a rising tide lifts all ships, and that's donation.
You guys are into this whole thing.
I'm messing up the metaphor.
He did it better.
Yeah, he did it way better. I didn't practice fluffing the drapes, apparently, but
I've never tried it, but it sounded good.
Yeah, pretty good. Donation is the answer, but when we talk about wasted organs, beyond just the cold time, when you look at the allocation, casting a wider net, we have people here waiting, and the best livers travel out, and the marginal livers will stay here. And as a result, not only do you have marginal livers here, but we get access to marginal livers elsewhere because all the prime organs are being taken by the local OPOs.
It all comes down to whether or not you can raise organs, raise donation up effectively. So, Dr. Taylor, help our viewers understand a Meld Score and how we determine seriousness and how sick folks are.
Absolutely. So the Meld Score, Meld, which stands for Model for End-Stage Liver Disease, takes 4 common blood tests.
And I think there should be a graphic about this. We're going to be seeing these numbers. There we go. Okay.
So 4 common blood tests that any doctor's office can order, any lab can order, and then you can put it into a calculator. And then that one number is like our biggest liver vital sign. So from that number, we can infer what your chance of dying from liver disease is, and we use it to then rank order patients on the transplant list. So it's a very useful number, and it's what we've decided decided to use to share organs, but it's not perfect.
So the reason we follow that is because I'm assuming, and I think, well, plus you and I have worked together for many years, but a high Meld score is associated with a higher risk of liver failure, and you're going to need a transplant sooner than later.
Absolutely. Simply put, your Meld can predict your risk of dying from liver disease, and that's why we use it.
Okay, and so is your sense that, I've been talking to these good folks here, but is your sense also that this is more of a problem of getting organs donated locally than a problem of distribution? And really what happened is UNOS changed the distribution system and hurt us.
Absolutely. I still believe a lot of it has to do with having organ access and the issues with the process, but at the same time, Meld isn't perfect for every patient. Some diseases may be underserved by Meld. I think we're going to talk about someone today about that, but at the same time, Meld score can vary between different disease states.
So tell me a little bit about that, because I'm not sure our viewers are going to make that association. Meld scores and transplant, tell us about that relationship.
Sure. So your Meld score at the end of the day predicts where you will be on the transplant list. And the whole process is designed to have the sickest patients first be transplanted, and that's reflected by the highest Meld. Now, some diseases, for example, people who are drinking alcohol can have very high Melds by the way that disease process affects their Meld score, where other diseases, such as some autoimmune diseases, fatty liver disease, may not have as high of Meld scores intrinsically because of how the body responds.
And so those patients may be at risk because the Meld score doesn't even represent them all that well.
Absolutely. That's exactly another whole layer of complexity with this problem.
All right, so man, there's so much, and so much of this just has to be handled locally when you're trying to make an informed patient care decision. I think that's really critical. Dr. Coomer and Dr. Schmidt, this has to be frustrating to be doing fewer liver transplant surgeries. Smaller transplant programs are jeopardized when the number of transplants decline. How's our program holding up? What's going on with that?
Well, I think our program is holding up fine. We've just really had a shift in the complexity of the list. The higher the Meld score goes up, patients are obviously more complex to operate on. But what I think is really sad is the unintended consequences of this process is we now see patients who are older, more frail, and we might not even list them. So there's less people getting transplanted and less people getting listed. I know every time we have selection meeting, we have a process where we talk about these patients who are sick, and then we might not list them because we know they won't be able to survive a high Meld score. And I think there's really unintended consequences of this whole process.
So if you wait too long, your score gets so high, means your liver, and you're in such bad condition that the transplant itself may be too challenging for you.
Yeah, you may be too frail, too weak to get through this transplant, and so we might not even be able to list that patient, because in rural Kansas, there's Medicare data that shows that people with liver disease don't get as much care as they do in big cities, and so we get them late, get them sick, and they might not ever make it to transplant.
Yeah, I think I've done a little work on lung transplant with you guys, and the challenge is always you don't want to transplant somebody too early because it's the risk of the transplant itself, but you also don't want to wait too long because then the transplant itself gets too hard and you don't survive. By the way, what is the survival like for liver transplant?
So patients with liver transplant can live a very normal and healthy life afterwards, and so 9 out of 10 patients are alive 1 year after a transplant, and considering the majority of those patients would have passed, that's pretty remarkable.
So what's the 10-year life expectancy after a liver transplant?
About 70%.
That's really high. I mean, that's probably higher than a lot of people might have had, even on their own. So that's a pretty big deal. Okay, so we were only able to retain 17% of donated livers. The rest we watched fly out of the state to other programs and other patients. We've talked a little bit about today, but what are some of the extraordinary efforts you've taken to increase the chances that our patients would qualify for donor livers? And I'm going to start with you, Ryan. What have you been doing out there?
Absolutely. Well, we've been cheerleading our patients first and foremost, helping them make sure that they're keeping themselves strong, keeping their nutrition up, staying active, so that their body can withstand these longer wait times for transplant. So we're talking to them more. We're speaking with them. Our nurses do an amazing job of reaching out and working with these patients and families to keep both their body and mental health stable to go through this process.
So we've watched our transplant numbers drop, which hurt our patients as our organs flew away to other places. But we've also had to start accepting all these other livers from outside. Tell us how that's impacted our program.
I think like Dr. Coomer was saying earlier, is that the organs in our area are usually allocated to people with Meld scores 32, 35. So the 18 to 40-year-old donors who are generally considered the perfect donor usually fly out to other places, Chicago, Dallas, Oklahoma. And then that leaves the older, more risky organs that could fail to our patients who are Meld score 28 to 32, is where our average is about Meld score of 30 right now. And so not only are the patients sicker, but they're also taking higher risk organs that have more complications. So the complexity of the whole process has risen, and the care and the ICU length of stay, hospital length of stay have all gone up a little bit, but we've generally been able to keep the survival rate the same, keep the length of stay the same. It's just a lot more intensive work.
So you're going to start tracking this data about how we tell us a little bit about why are they tracking it now? What's changed?
Well, I mean, I think they're tracking all the data. They always have, and I think that, as outlined previously by Dr. Schmidt, they are responsible for allocation. They're not really responsible for donation. They're tracking some of this data. First of all, they have been taking credit for donation increases. They have nothing to do with that. They have taken credit for increased liver transplantation, which they have little to do with as well. They have something to do with it, but they're tracking the data, and you assume it's for good reasons. Sometimes it's nefarious, sometimes it's punitive. So I think they're looking at, well, what's your discard rate, and that can be falsely inflated in places like here, because if we're offered more marginal organs than another center in a larger city, they will have a lower discard rate inherently, because we don't want to hurt our patients. And I think that's the problem in following that metric in particular.
Yeah, so it's kind of like, let us justify what we just did, and we're going to find a way to do that. All right, so Ryan, have the patient outcomes since the allocation changes of 2020, are they the same? Are they different? What are the challenges of caring for sicker patients post-transplant?
It's really hard taking care of these patients waiting longer for transplant. They get sicker, they're more likely to get infection, end up in the ICU on life-saving life support. Patients can have more problems with swelling, fluid retention that just impairs their ability to eat, to walk. They get worsening problems with their brain fog as a result of their liver disease, so they become completely impaired. They can't drive, they can't balance a checkbook. So really, it makes our patients more and more disabled. And so you can expect all sorts of medical issues can occur.
Well, I think this idea of having to travel out of the area is just hard. My brother had a lung transplant a number of years back. He passed away about 4 years after that. Had a great life on his lung transplant, had cancer. But the challenge was going back and forth to the transplant center. That takes a lot out of a patient. So I would think the closer patients are to their home, the better off they are. It's just hard when you have to travel and you take someone with a chronic disease, and not to mention expensive. Well, recently one of our transplants, Gary Gray, traveled to Philadelphia for a living liver transplant. Dr. Taylor, tell us about this patient. I understand his liver illness meant his Meld score might not ever be high enough to get a shot at a liver. Talk to us about it.
So Gary had a type of autoimmune disease where his liver blood test would not go as high and reflect in his Meld score. And Gary here in Kansas City was just getting sicker and sicker. He was having more and more problems with that brain fog that I mentioned. It was becoming more and more impaired. So I knew his quality of life was suffering. He was losing weight. He was going down the tubes, and we needed to get him transplanted. And with his low Meld score in the current system, I knew that wasn't going to happen here in Kansas City. So we had discussions about looking at options for living donor liver transplant.
All right, so that's a pretty big deal. But he found his own living donor. Surgeons, help our viewers understand how a living person can donate part of their liver.
Well, most donors that you hear about transplant are whole donors, where we take a deceased donor, someone who's had brain trauma or other factors that would lead them to be a donor, and we use the whole liver. A living donor is where we take, like, I would donate half my liver to Dr. Coomer, and my other half my other half would regenerate, and so both, he would have a half a liver, I would have a half a liver, and the liver is so impressive that you can take half of the organ and it will work in another person, and you can just use the blood vessels of half the liver versus the whole liver.
You know, it's pretty amazing we can even think about doing that, and it's got to be a lot of work, a little extra risk to the person who's making the donation, but they're doing it out of love and concern. What a great gift. You'll have made mention earlier this year on this program that we are going to start a living liver donor program. There's a lot of L's right there. What does it take to start up that program?
Well, mostly it takes expertise in training, and that's what we've been doing over the last 6 months to 9 years. Dr. Coomer and I used to do them in the University of Virginia, but you have to become recertified, and we've been in the process of doing that with some of our younger faculty and hope to start in the next 6 to 9 months.
That'll be really exciting and another way to do that. So just to think about it for a minute, what are the next steps? Because we keep talking about UNOS and process, and I heard the secretary say we're going to examine this. Nothing's changed yet, though, really, right? Well, what's going to take to make a change here? Come on.
You know, I think this was a big step. The Washington Post, this story's been kind of out there for quite some time, and it finally got out to the public. I think that's a big step because what you felt was we didn't really have a seat at the table, although we pushed our way into it a little bit, and not just us, but others around the country. Making this a national story is a huge deal. You know, and Dan Peters deserves a lot of credit, as well as his colleagues around the country, to keep this going. That's the first step. You know, Senator Moran, Senator Blunt, Congressman Yoder previously really were champions of this area. Senator Grassley, some others around the country have really helped champion this. And I think that's the first step. I think it's also going to be education, number one. It's also going to be having a seat at the table and being involved in the new process and the new contractor, if that comes to bear.
All right, yeah, a special shout out to both Senator Moran and now the retired Senator Blunt from Missouri. Man, persistence, perseverance, and determination on their part helped to make sure this never left a front issue in the legislative process, and I think it's a big reason why we were able to get some of this done. Hey, I hope you're asking questions in the chat threads on YouTube, Facebook, or Twitter. You can also email questions to the Medical News Network. The links are on the screen. Your questions are next after we check in on the COVID count. Hawkeye, how's it going today?
It was a little bit better earlier in the week, but we've had some increase in our number of total active cases. So I think yesterday we were up to 29. We are still at 29, 44 total. Unfortunately, we had a dip in the ICU, but now we're back up a little bit, 6 in the ICU and 1 on the ventilator.
You know, lots of big headlines out there today are still around COVID about the World Health Organization. They updated their COVID-19 vaccine guidelines. They want boosters between 6 and 12 months. I think the FDA was kind of tilting towards 12 months. Healthy children are low priority. The FDA has not weighed in on the World Health Organization recommendations. Hawk, what do you think?
You know, I think as far as the younger population, I think that is very reasonable. We know that, number one, the younger people are less affected, although they still are, but they still do recommend that the younger population does complete the primary series and get at least 1 booster. And they are just saying we want to shift prioritization to those higher at-risk populations. And I think for the World Health Organization recommendations, that is certainly good. Our CDC and FDA will take that into account as well.
Yeah, as I look at the data, we continue to see downward trends in hospitalizations, which I think is now the new bellwether. I don't know what test positivity rate means anymore, Hawk, and I think there's a lot of question of hospitalizations, which are going to be the first sign, and the other bellwether will eventually be death. But there's a lot of difference between the first thing that has to happen is you got to follow hospitalizations. Yeah,
I agree, and I think in those hospitalizations, Steve, those are going to be those most at-risk patients with several comorbidities, including age, but also our immunosuppressed patients like our liver transplant patients as well. And so I think it's really going to be prioritizing those groups to keep them most protected to help reduce their risk of hospitalization and severe disease.
And we know that not only do you need that primary series, but if it's been more than 6 months, you need to get your boosters and that bivalent booster. When we look at our patients who are being hospitalized, if you're up to date on your vaccinations, meaning you've had your booster shots, you just don't come in the hospital very much.
Yeah, absolutely. I think the bivalent booster has shown clinically to help reduce that risk of hospitalization, severe disease. We also know the FDA is looking at weighing in on for those highest at-risk immunosuppressed patients and populations. are you going to need a booster at 6 months? I think moving forward, though, I think it will be very difficult for the vast majority of the population to continue to have recommendations of you're going to need a vaccine every 6 months. I don't know that that's needed, but we should certainly focus and prioritize those highest at-risk populations. But also, we remember we still do have Paxlovid, which continues to be a very clinically useful drug, and that can help reduce the chance of hospitalization, severe disease, especially for those at-risk populations.
All right, well, thank you.
Yeah.
Those are really important points, I think, and hopefully our good folks are out there listening today. Any reporter questions today, Jess, before we go to community questions?
No, but we've got some good ones. And the first one, I've just got to say, Janet just sent in with a little heart emoji. She said that Dr. Schmidt is an amazing surgeon. So I had a little love.
We're just, okay, we're good. We're just growing.
Next question.
In case you can't tell,
that's
we
it.
happen to all know each other pretty well on this panel today. So
That's it. That's all I got. Nothing else. That's it. Just Schmidt's amazing. That's all they're going to say. When Coomer's on, and when Coomer's on, we get the same stuff. Okay, so who runs UNOS? Joellen wants to know.
So UNOS has actually gone through a leadership change recently, and because of some of the things that have gone on with this allocation, some missteps with it, I believe. They have an interim CEO right now. They are a private contractor led by a board as well as an executive team, but they're a private contractor of the government. So they applied for and received the contract, and they run the allocation system, but they have their own private executive team that runs that.
So they're not part of government?
They are not, aside from owning the contract.
So they have a company and the board of directors who are probably very influential. How are they determined?
Do you want to take that one?
I was actually on the board in 2018, and it was really, you're kind of voted on by your peers, but as I got further into the process, the leadership of the executive committee really kind of picked out people who were kind of groomed for the board. Well, this person would be this person could fit this role. So it's really the small executive group would run the board, and the board members were just there for more of decoration versus actually having input in how the process goes. Because when the allocation changed in 2018, I think 80% of the regions voted for it not to happen like it did, but it still happened and the change was made. So it's a private contractor. They make a lot of money from the government, and patients actually pay UNOS to be on the list. So that's where they get the majority of their money, is through patients.
So it's the board is from a mix. It's geographic by region.
Yeah.
So and Dr. Schmidt was on that board at one point, and then also it has at-large members that are sort of picked by sort of leadership in UNOS, and then there's other folks like donor families or recipient families that might be on there as well.
Okay. Jess.
So Jeremy has a comment and a question. He says, I imagine the idea of doing a living donation can seem really scary, not knowing what it all entails. What would you tell someone who's considering providing a living donation so they understand and maybe aren't so fearful about it?
I think the advantage to a living donor is obviously we're going to look at the donor and make sure that they're perfectly healthy. We don't want to operate on someone who is not perfectly healthy. So their risk of a complication is not that significant once you select the patient right. So healthy person, normal liver, normal other parts of their body, so their risk is not that high. But the advantage is the patient who they're donating to can get a transplant sooner. They don't have to wait as long. It becomes an elective operation. You know where the organ's coming from. You can time the surgery during the day. All those things lead to the patient getting off the list sooner and doing well longer.
Good stuff. But it is a big deal, and you think the ultimate act of sacrifice, people giving kidneys, giving part of their liver. I know parents, and there's a small population of even lobar lung transplants where you give a little bit piece of your lungs. So it's a big deal.
It's a big deal, but Dr. Coomer does our donors for the kidney here, and I imagine patients don't usually have regrets. I don't.
No, not usually. It's that's one of those things. It's a great responsibility on us as caregivers to be the the executor of the gift, but it's really a gift from the donor, and it's pretty incredible how giving, how they feel about it, how they're able to help a loved one, and even folks come forward as altruistic donors. They have, the feeling they get in response to that is incredible, and when it's for someone they know, it's even much more bonding.
And I'm taking it that these patients, after they come back to you and follow up and all that, who have got this living they've received the living donation, I take it they do really well.
Amazing, amazing. I just saw Gary last week. I almost didn't recognize him with how much better he was doing after his transplant. It's only been a couple months.
Yeah, that's remarkable. Jess.
Alice wants to know, how many years does a stage 4 colon cancer person need to be out, no evidence of disease, she says, to be put on the organ donation list?
Ooh, a donation list. Okay, guys, what do you think? Can you be an organ donor if you've had stage 4 colon cancer? That's tough.
If you're stage 4, usually that means the cancer has spread, so that would most likely rule someone out to be a donor for a transplant.
Because when we think about the colon cancer dynamics, it drains right into the liver, so
Yes.
there's still likely to be some old disease. Then you put people on immunosuppressants, even if you donate the liver to a new person, those drugs to suppress the immune system, man, there's a good chance that cancer could return, I think.
Anne wants to know, can a donor stipulate where an organ goes if they want it to stay local?
Wow, someone got right to the heart of that question, or in this case, right to the liver of that question.
That one.
Yeah.
I'll take that.
We're all gonna be
I'll jump on that one. So donors can specify a recipient. That is it. They cannot specify characteristics of a recipient. They cannot specify a location of the recipient. It is only direct donation to an individual that is allowed.
So, Dr. Coomer, that means like if I wanted to, like when I die, I could say if I die and my son needed an organ, they can have it. But that's the only stipulation I can make.
Correct. You have to identify an actual person, not any other characteristics.
But there's no, okay, so that's what she was wondering about, trying to keep it local. Jenny wants to know the difference in trying to find that kidney donor versus trying to find a liver donor. What are the differences in that search? What are some of the challenges that patients have?
Well, a kidney, we obviously have 2 of them, and so it's a lot less of an operation to take out one kidney than it is to take out half of a liver. So to be a liver donor, you're probably younger, healthier, obviously non-obese. So you have to have almost everything perfect to be a liver donor.
It's just a bigger operation.
It's a bigger operation. And then the liver anatomy of is so variable that you have to make sure the anatomy of the liver is suitable for one, you leave a good piece behind, and one, you're taking a good piece to someone else. So there's a lot more complexity to a liver donor.
And when somebody is a donor for a kidney versus donor for a liver, or even a deceased donor, if I remember right, kidneys can travel a lot further, a lot safer than livers can for a lot longer. Is outside of the body. Still true?
Yeah, that's definitely fair. Kidneys can usually last on ice, usually 24 hours. And when we talk about livers, it's usually 6 to 12 hours. I know that our center really pushes to get livers in within 6 hours. We feel like the outcomes are much better that way. We push to get organs in faster no matter what they are, kidneys as well. The longer an organ stays on ice, just the poorer outcome.
Yeah, but just because when we say on ice, it's not getting blood flow, it's not getting oxygen. The ice and the preservatives have helped to slow its metabolism down, but still,
it's slowly dying.
It's slowly dying. Yeah, well done.
All right,
Yes.
last question, and I'm loving that all these questions are people asking how they could possibly be a donor. So that tells a lot about the people around here and our viewers. So Vera wants to know, if somebody had hepatitis C and went through the 12-step program and is now, quote, cured, can that person still donate?
Absolutely. Absolutely, and we even can accept donors from patients who are positive for hepatitis C because the medications now cure almost everyone that gets the medication.
It's a changing world all the time.
Yeah.
All right. Well, let's get around to some final thoughts. So this has been a great program. I am grateful for our guests for being here. I'm grateful for them putting up with me because, again, I've known these guys for a lot of years. And I know them to be outstanding human beings and amazing physicians. So let's get some final thoughts. Dr. Taylor, I'm going to start with you.
I think this has been a great discussion. I think that first and foremost, we want the public to be aware of these challenges, because you never think about liver disease or needing a transplant until you get sick. And then these issues become very, very important to you. So having the public's voice and community voice on this is so critical for these conversations.
It is a big deal. Dr. Schmidt.
Well, I'm excited about the UNOS and competition and transparency. As everybody knows, if there's no competition and there's a monopoly, and the processes that happen are not known to the group, then things can happen that aren't necessarily efficient, cost-effective, time-savely, better for everybody. And we've argued for years we want a process that's quick, efficient, and effective, and saves more lives, and I'm excited for competition.
It's a big darn deal. Dr. Coomer.
I like to focus on donation. I mean, I think that, as has been said before, we have more donation and we have more transplants. And as Jess pointed out, everybody's asking about donation, and I think that speaks volumes about our area of the country, because that's what we fought for in this allocation process, is that the folks that donated here locally, the organs stayed locally and helped their community, and that's the success of this area, and a transplant program blossomed around it. And now the organs are going elsewhere. But nonetheless, no matter what we finally land on with allocation, donation's the basis, and that's the gift. And that's why folks that do give are true heroes and angels.
Dr. Hawkinson.
Yeah, it's always good working with our surgical colleagues and our other internal medicine subspecialty colleagues like Dr. Taylor with liver, with hepatology, and I think that just goes to show you this happens all day, every day at the University of Kansas Health System. All of these teams collaborating for one goal and one thing only, and that is to get you feeling better, get you back on your feet, and get you home and keep you home and safe and healthy. And I think this group here is a good example of that.
I think, Jess, everybody needs a hero. And I think we've needed heroes in this. And I want to say a special shout out to Dr. Moran, or to Senator Moran, and to now retired Senator Roy Blunt from Missouri. These good folks are heroes because they helped us change this landscape at a national level. And to our own Dan Peters, who was one of the voices in the wilderness as we started complaining, and all of our physicians and teams started talking to our system. Dan helped to construct a coalition of folks to keep this in the front and in front of the legislative process. And you saw the result of that at that opening video with Senator Rand talking to the Secretary. Heroes are great, and we have heroes who are donors, both deceased and living, and there are heroes who are our patients. They're the reason we're here every day. They're the reason we're going to keep being here every day. We all need heroes. When we find heroes in each other, I think that's just the best. Jess, back to you.
All right, Stites, Dan, Coomer, Taylor, not Schmidt, because he gets enough love. Here are your little heart emojis from me. Straight from me to you, okay? Our big heroes. So, guys, thanks so much. A lot of love on here today. Georgianne was just saying, just hats off to you guys, and thank you so much for the program and all the information. And thanks again, always, to our viewers. We'll be back here tomorrow, 8 a.m. for another morning medical update. Have a great day. Coming up tomorrow on the Morning Medical Update, millions of people live with long COVID, and we're still learning about it. Admiral Rachel Levine is leading the research effort. I'm Jessica Lovell on the next Morning Medical Update. The national public health leader joins us to explore the crucial research happening right now, giving better care for long haulers. Thursday at 8.
I'm Alexis Del Cid. On the next All Things Heart.
Because I was, too stubborn to die.
Undergoing one organ transplant is huge. This patient had 2 organ transplants at the same time. We share his wild journey to better health, along with the doctors who saved his life. Thursday morning at 10.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now, everywhere podcasts are available.